Everyone. I want to thank Embry for their generous support. And I have a lot of slides, but I'm going to make it very quick, 5 minutes. So we know that autism spectrum disorder is a common disorder and is a costly one. The incidence is increasing. Either it's because of better diagnosis or an actual increase. We don't know. And we know that autism spectrum disorder impacts academic performance. There is need for services at school, and it also impacts your employability, so it's very costly for the society. And based on the DSM criteria, it is defined as limitations in reciprocal and social interactions, as well as restricted and repetitive patterns of behavior. Limitations in language function are common, but they're no longer necessary for the diagnosis. We believe that at the heart of autism spectrum disorder, we have dysfunction of mirror neurons. These are visual motor neurons that are located in the inferior frontal gyrus and inferior parietal lobule. These are activated when you're observing other people perform an action, and these neurons allow you to look at that person, look at that person's behavior, emotion, and then be able to understand them and reciprocate. So you can imagine why, with this functioning of this network, you can have autism spectrum disorder. Obviously, you would have difficulty understanding and analyzing other people's emotion and reciprocate. And also, these neurons have a very important role in acquiring language, right? And TMS is an innovative research technique and is very attractive and popular in neurosciences at this point. And we know that transcranial magnetic stimulation alters cortical excitability, and the effect on the cortical excitability depends on the type of stimulation that you're using. Essentially, with high frequency stimulation, you increase the excitability, and with low frequency stimulation, you decrease the excitability. With high frequency stimulation, you also have the chance of increasing the amount of BDNF, brain-derived neurotrophic factor, and therefore you can produce new networks. And that's the process that we know as neuronal plasticity or synaptic plasticity. And therefore, we can have some longevity in the effect beyond the few hours after the stimulation. And these effects probably persist for months. Now, this is a picture of the machine. The magnet, as you can see, is hanging on the bar, is what we use for the stimulation. So the existing literature that I have reviewed shows that there have been quite a few experts who have tried using TMS for treatment of autism spectrum disorder. Majority of these experts use low-frequency stimulation on the dorsolateral prefrontal cortex. And the rationale they used was that the frontal lobe is excessively inhibited in autism, too much GABAergic activity, so they used low-frequency stimulation to inhibit the inhibition. And there is also a very good meta-analysis on these literature. Essentially, the collective results tell us that there was a favorable response in terms of social responsiveness, language, executive functioning. And however, the majority of the experts used very conservative approach of low frequency stimulation. They were afraid of causing seizures, so they all used a very conservative approach. And one major limitation we have on these published literature is that we didn't have controlled studies, and we had small number of studies of subjects in the studies. And also, we don't have consensus about what is the best area to target. Sorry, got stuck here. I'm sorry, forgive me. So we, the rationale in our studies focusing on the mirror neurons with the understanding that this is really the heart and the soul of the autism spectrum disorder. And we established this work based on preliminary data of testing 4 patients a few years ago. And we basically recruited 4 patients. We used neuropsychological test battery before and after. We did 9 sessions of TMS, and these are our results. We can't go into detail, but we definitely had a trend towards improvement in terms of social cognition and verbal fluency. So in this study, we are including patients with DSM who fulfill the criteria, DSM criteria for autism, and we're excluding the patients who have any history of seizures or predisposition to seizures because one of the adverse effects of TMS may be producing seizures. We are delivering high-frequency stimulation of 10 hertz, and we do 2,000 stims per session. We are doing a total of 10 sessions over 5 weeks. And we are randomizing these patients to receive either the right inferior parietal lobule stimulation or the left side. So in essence, we are doing comparison before and after, but at the same time, we have the opportunity of comparing the right side and the left side. And this is in an attempt to perhaps create better guidelines in terms of the stimulation paradigm. So we are randomizing. The active side is either right or left, and on the opposite side, we are using a shamming technique. And the battery of neuropsychological testing we are using before and after include NIH toolkit that includes measures for mental flexibility and attention, as well as testing for verbal abilities, verbal fluency. At the same time, we are using 2 standardized scales for measuring social cognition: social responsiveness scale and repetitive behavior scale. These are standardized, and we basically have numerical values that we can compare before and after. The major barriers that we see are obviously parental anxiety, and also the fact that they have to commit to 5 weeks of treatment. That's a little bit tough for any family. Contact avoidance is a major problem in patients with autism. So it's hard to negotiate with them sometimes, and you have to pick the good candidates, essentially. And anyone with seizures obviously is excluded. One major barrier that I am seeing right now is the male predominance in autism. We know that autism predominantly affects boys, and that's why I'm having difficulty recruiting girls. And the potential risk to the patient essentially is a risk of seizures. I can tell you that's extremely rare. So in a review of 35 trials, basically only 2 patients had seizures, and that's 2 out of more than 1,000 patients who had been recruited for those studies. And the high frequency stimulation rates of 15 to 20 hertz are more likely to produce seizures. So obviously we avoided that, and we are excluding all patients with seizures. And as of now, we have recruited 5 patients. Yesterday, I recruited 1 more. 1 has completed the study. 1 is in the middle of the TMS treatment, and the others are scheduled to come in. And I'll be happy to answer any questions.